What happens when science becomes politicized and when medicine becomes politicized? Nothing good. We're going to present some of that today, and we're going to be looking at the possibility of a second wave and how we get past all of this. Hello, everyone. I am Dr. Chris Martinson. It is May 15th. I'm here on day 113 of reporting, and I've titled this one Second Wave. I've got my good friend, the honey badger, back there, and he's waiting patiently with his sharp paws folded over there as he waits our next moves as a culture to see where we go. Now, before we dive into the science or the bad science or whatever we're going to call it, I'll let you decide. Let's get into the email of the day. And this one really, I really love this one. I love them all, but this one caught me today. It says, "Hi, Chris. I just wanted to let you know how helpful your hard work has been for me and my family. I've been watching your videos for a couple of months now, and I wish I'd known about them sooner. In addition to the incredible info you provide regarding COVID-19, for me, it has been inspiring to watch science-focused videos. Personally, I don't like the terms good science or bad science. For me, science is always good. Bad science? It's just something else. Could be greed, stupidity, or just plain lazy." I agree. I guess it isn't bad science because it's not even science at all. There's good science, and then there's something else. I like that framing. I'm a wife, mother of two, and a psychiatrist who graduated a couple of years ago. I have been so exhausted these couple of years getting my career started, being a mom, being a wife. It has been very busy. I had lost touch with that part of myself that is in love with science. Now I feel I have fallen in love with science again, and I thank you for that. In regards with COVID-19, I don't know if I'm able to express how great your research and explanations really are. Because of your logic, common sense, and science-focused research, I'm able to trust you, and it saves me a lot of time from doing the research myself. With that time saved, I'm able to spend more time with my family and getting prepared for what's coming and for what's already here. And also because of you, I also watch Mike Maloney's videos. Wow, they are also incredible. Best wishes from Puerto Rico. P.S. I'm a private person, prefer my name not be mentioned anywhere. Thank you again." So to this person, who shall go unnamed, that whole idea that you managed to get in touch with science again, that touched me. It's really one of the nicest things I could have received in an email, and so I thank you for that, because I'm working as hard as I know how to be an educator and to, believe it or not, it takes quite a bit of effort and quite a bit of training to be able to take complex things and explain them in a way so that people can get them. And honestly, you know what my method is? My method is I keep digging at something until I can explain it to myself in the way I wish somebody else had explained it to me. When I created the crash course back in 2008, I did it because it didn't exist. I kept looking for it. I'm like, why hasn't somebody put these dots together like this? And so that's what I did. And so I'm here digging through all of this because our future all depends on how we get through this particular pandemic. And it's not just that it's a virus and you know what, we'll get past this. People got past polio, as the title of yesterday's presentation was, that this is this generation's polio. Yes, you could look at it a couple of ways and say, well, the fatality rate's not all that high. We'll get past this. That's true. But this is coming at an awkward time in monetary and financial and economic history, where we have an entire financial system for the past 50 years has been predicated on always having more debt in the system, which both it allows us to live beyond our means, sure, but it also introduces and injects a lot of fragility into that financial system. Here's what most people don't know. Most of the last 50 years has been people in Western countries living beyond their means, borrowing from the future, trusting that the future would always be bigger than the present. What happens if that's not the case? Well, COVID came along and said that's not the case. It just destroyed that model. And so now we're going to discover not only do we have to live within our means, but we might have to, in essence, pay back all those decades of living beyond our means. So that's why getting our response to this right takes on such incredible importance. And then on top of that, we have all the environmental and ecological effects going on, which guess what? We humans have kind of creviced out to the edges of the all corners of the globe. And now we have to begin to live within ecological budgets too, right? And what do I mean by that? Well, there's only so many years you can strip mine soil before you've taken all the macro and micronutrients out. If you do it too long, you turn soil into dirt. It basically becomes an inert medium that you have to pour NPK, the primary fertilizers, as well as the micronutrients back on so that you grow foods that are even worth eating at all in the first place. And so we have a topsoil budget. We have a fisheries budget, right, which we've exceeded in most cases. We have a forestry budget, which is being vastly and badly exceeded in the rainforest. We've got all kinds of ecological budgets, all of which coalesce into this idea that it's time for us as a species to be able to wrestle with both complicated and complex ideas and navigate them successfully. So in many ways, COVID-19 then becomes a litmus test to answer this question. Can humans respond appropriately and in time and in a timely way to a threat that is both complicated and complex? I hate to tell you this. The answer so far, at least in some countries, especially mine, seems to be no. But let's go through this and step through it. For people who are new to this series, I just want to remind you the series began a long time ago. I issued my first alert back in January 23rd. It feels like 10 years ago now. That was such a long time ago. And I called it then, quote, as having all the hallmarks of a true pandemic. And those were the hallmarks of the virus itself, which I managed to study and understand by then. I put out a video to the world on January 24th that articulated these risks. And I said, this is a very, very big deal and you need to get prepared. I asked people to become personally prepared, buying masks, getting food, whatever basic preparations they needed to undertake. On January 27th, I personally declared this a pandemic because I was still back here. We were at phase 4 of the WHO pandemic guideline. I was waiting for confirmation that we got to stage 5, and we got there. And I called for an immediate halt of all flights from China because I understood it probably just doesn't make sense to continue to have infections flying around if you want to have any hope of stopping it. On February 2nd, way back then, I reported on both the asymptomatic and post-symptomatic transmission of this virus. People are still confused by this. Many of them just politicians, I get that, but they don't have the science training. But this is a long time to get your head around some basic data, and some people still aren't there yet, especially the people I note who are out in public protesting that they want to have their freedoms back, they want to have their personal responsibilities back, but they're doing that without wearing face masks. If you do that, you're basically saying, hey, I'm irresponsible and I need a government to tell me what to do because clearly I can't manage that for myself, right? So this whole idea of people who are saying, I'm not wearing a face mask because it violates some individual capital L libertarian sense I have, that's just hogwash. You know, if you lived all by yourself without anybody else around, go for it. Wear as many or as few masks as you want. Of course, you wouldn't need to wear one if nobody else is around. But when you're in public, and I'm part of that public, you do not have the right to not wear a mask and try and infect me. That's where it all stops, that personal, you get to do whatever you want thingy. So grow up if you think you have the right to not wear a mask in my presence or anybody else's presence, okay? Yeah, it's just really not a right you have. February 4th, I noted that China was fudging their data for both a number of cases and for deaths. They were putting these quadratic fits on what was clearly an exponential function. It was just bogus. And then on February 9th, presented aerosol data, and then this just ticks down, and we could go through day by day. And what I'm trying to do here is show that just using logic, using science, using reason, I was able to deduce all of these things from press reports, from scientific papers, from basic deduction, things like that. So at any rate, that's continued, and there's a lot of stuff out there. But for those of you who are new watching this, I just wanted to give you a little history so you didn't have to go back and watch all that stuff. All right, I wanted to also harken back here, hydroxychloroquine, right? If it's a buck a pill, it could be a pretty easy and cheap treatment. Remember, this was from April 6th, daily update. So today being May 15th, a month and a week ago. Here's what you do if you want to have hydroxychloroquine treatment be effective at all. You got to start early. The sooner the better. Why? Because it's antiviral. When do antivirals work? Well, back when the virus is really replicating in your body. Once you're on a ventilator, it's just too late. I deduced that a long time ago. Might hydroxychloroquine work prophylactically? That is, can it stop you from getting the disease in the first place? How would we put this? So a lot of things work prophylactically. So I'm struggling now for a quick analogy that's not a condom. But at any rate, could this work? Well, this is the India data presented a long while ago. They said, yeah, it kind of does. You know, we give this to our frontline workers and they don't seem to come down with COVID-19. Pretty cool. Hey, it's not for everyone. Of course, we noted that. There are plenty of comorbidities that would exclude its use, some of them cardiac, some of them beyond that. All right, moving on. If you want to conduct a proper hydroxychloroquine study, and let me just see. I think I should put that right in there. Let's put that word in. If you want to conduct a proper study, it has to be a randomized trial, full stop. And this is from April 27th. Daily update. The treatment has to be begun early. Treatment begun early. Start that as soon as COVID diagnosis or, this is important, upon appearance of suggestive symptoms. Somebody comes in with a fever or a cough and they're not sure if they have it, or maybe somebody they've bumped into has COVID, just start the treatment and then test them later, or test them whenever you can get around to it. But for goodness sake, you have to start this as early as possible. And you want to record the doses that are used, of course, as well as the dosing frequency. We were reacting here to a study that didn't do those things. It's not really a study. And the zinc. Of course, zinc has to be included. And you want to have the blood levels tracked if possible so you can correlate those two things. Maybe some people have problems absorbing zinc. Maybe they had unnaturally low zinc levels to begin with. Maybe their zinc levels were higher. But at any rate, there's two reasons you take hydroxychloroquine. One, and both of these are inside the cell. So a cell that's going to be infected with a virus, if you're using hydroxychloroquine, one, hydroxychloroquine is an ionophore, means it makes a hole for ions, an ion pore, if you will. That ionophore activity allows zinc to get inside the cell, and it allows cells to share zinc between them. So it's an intercellular ionophore, makes a hole in the cell wall, and allows zinc to go back and forth, apparently. All right, that's pretty cool. Because cells help each other out when they're fighting off a virus like this. But within a cell, if you have zinc in there, it helps to stop that. It helps the cell to stop the RNA replication. The second thing that it does is that for whatever reason, hydroxychloroquine goes in, and there's an intracellular organelle, a little tiny vesicle inside called a lysosome. It lyses things. It breaks things down. It's like a little garbage dump in there. And what happens in that garbage dump is a fire gets lit and it burns all the garbage in it. Well, in this case, in the lysosome, the cell tucks things in there that it wants to break back down again, like, used up extracellular receptors or defective proteins or anything like that. The cell puts them into the lysosome and it breaks them down with a lot of proteases and acidic environment in there. At any rate, that's one of the ways that when the virus, this COVID-19, binds to ACE2, that whole receptor complex with the virus gets internalized and brought into a lysosome. And there's a set of conditions in there in terms of pH, in terms of proteases, all that operate at certain pHs that are required for that virus to escape the lysosome and get into the cell. Well, hydroxychloroquine raises the pH and seems to block that function. So a couple of ways that hydroxychloroquine works, well, you need to include zinc as well in this whole thing. And I said plus minus, use it or don't. Azithromycin, if you really want to parse it all out, so you could try, a really good study would be randomized, placebo-controlled, with and without zinc, with and without azithromycin, varying dose levels. That'd be the gold standard. You'd have all this data you want, put thousands of people through it, right? But if you don't have a good reason to exclude it, then include it. Might as well, if it might work. Okay, that's what a proper study looks like, okay? Well, it was just announced that the NIH is putting out this really big study, and they're finally, here we are in May. We called for this stuff months ago, and finally evaluating the efficacy of hydroxychloroquine and azithromycin to prevent hospitalization or death in persons with COVID-19. NIH is finally coming forward with this whole thing. I'm asking, is this just designed to fail right up front? And if so, morally speaking, is that an okay thing to do? Answer obviously is no. Here's a detailed description of this thing. This phase 2b study will evaluate the efficacy of hydroxychloroquine and azithromycin to prevent hospitalization or death in symptomatic adult outpatients with COVID-19 caused by SARS-CoV-2. Participants will be randomized 1-to-1 to receive an active placebo, so it's placebo-controlled. Love it. Study treatment as follows. Hydroxychloroquine and a placebo, 400 milligrams orally twice a day, BID, on day 0, followed by 200 milligrams orally twice a day for 6 days. So they've got a 7-day treatment of hydroxychloroquine plus a placebo. And then they have azithromycin and a placebo, where they're giving 500 milligrams of azithromycin once a day on day 0, 250 milligrams a day for 4 days for a total of 5 days. So that's the placebo. Either you're getting HCQ and nothing else, or you're getting azithro and nothing else. Stratification will be by high versus low risk of progression to severe COVID-19, where high risk is defined as a person over 60 years of age having at least one of several specified comorbidities. Participants will receive study treatment for 7 days and will be followed for an additional 23 weeks. Assessment on a subset of 200 participants will include blood collection, self-collected nasal swabs, and nasopharyngeal swabs. So the swabs are there to detect viral loading, and I don't know what they're doing with the blood collection, but I hope they're studying for something important, which would be zinc. But you know what? When you take this here study, and I pull the whole thing down, and by the way, this is the complete description of it down here. There's the URL. When you do that and you run a word search for the word zinc, no results. Zero results on zinc. Now, why is that not a cool thing? Well, because we've known about zinc forever. Long enough for me to talk about zinc a really, really long time ago, right? You know, everybody, I mean, if I know about this, certainly the clinical designers here should know about it. And we presented the data yesterday that showed that with HCQ plus azithromycin, with zinc and without zinc, look at these huge, giant, very, very significant findings that zinc provided additional extraordinary benefit to how many were discharged home, how many needed ICU or didn't need ICU in this case, how many needed invasive ventilation or actually didn't need, half as many here, how many expired, half as many practically, certainly, and it was half as many once you controlled for the fact that you excluded all the people who were in ICU, who were in serious condition. So guess what? If you're going to do hydroxychloroquine, there are two key variables you want to include. Two. One is zinc, and the second is time in terms of early administration. Okay? So when I looked at how they actually set this whole study up, my criticisms of it, which if I could get to them, I would love to give them these criticisms. First, criticism number one, no zinc in here. Two, they are going to require people to be COVID positive before they would even begin to include them in the trial. So that requirement of a COVID-19 positive PCR test, well, first off, false negatives are a thing still. They happen, right? The test isn't completely accurate. Two, it leads to a slippage of time for early administration. I don't know how long the tests take, but even if it takes an hour, that's an hour you missed. But it's, some of these tests take a day or more to return the result. So my question is, why would you just not administer the HCQ plus, and that includes the zinc and the azithromycin, on positive symptomology? They've presented, right? There's some reason they're there in front of you as a clinician. Maybe they've got this thing. And why don't you do that and then test them, right? You know what? You could always exclude the people who come back negative after the fact. You can always exclude negatives, but you can't get the time back. So they're going to take everybody and force them to wait until they have a positive COVID-19 return before they include them in the study. And I'm thinking there's another way you could design this, which is more humane. And three, in this study, there's no clear control of the timing. That is, how soon relative to symptoms before you start somebody on here. They should have declared it very clearly. I would tell them this: if somebody is presenting to the hospital, they've been symptomatic at home for more than 7 days, you probably ought to exclude them, because we have the study data in hand which says that if you administer hydroxychloroquine late in the viral progression in somebody, it doesn't do any good. Why? Because it's an antiviral agent. After the virus has already exploded and gone through its exponential increase in your body, it doesn't do any good to give hydroxychloroquine, because it's not how it works. It works to inhibit the virus from really gaining a foothold, and it works to give your body more time before the virus really explodes in numbers. It causes your body to go into that cytokine storm overdrive, which is the damaging component of all of this stuff. And how do you give your body time? You give zinc, and you give hydroxychloroquine early administration. That's how that goes. Because remember, to conduct that proper study, you really need the zinc in here, and you got to do it early. Okay. So when I looked at this too, I was really bothered because let me tell you what I do like. I love that it's randomized. I love that it's placebo-controlled, double-blinded. I think that's fantastic. Been waiting for this. I love that it has 2,000 participants they're seeking. That's going to give it a lot of firepower. What don't I like? Well, the primary completion date is not till October 9th. What? And the estimated study completion isn't for a year from now? Well, a year minus 10 days. That's why it's so long. That if you're giving this to people, you should be able to get results back within, 5 to 12 days. Once you start people on this stuff, you should have pretty decent data. Remember, for remdesivir, they started the trial and they stopped it, just a few days in, relatively speaking, because they said, wow, we had this great data come in and it turned out, listen, just as many people died and there was no statistical significance in terms of overall outcomes, except in this one area, we found that it shortened the duration of the hospital stay, we think, in a statistically significant way. And so they stopped that right away. But look at the length of this, a whole year to study something that probably you're going to get data back. I kid you not, within 12 days or so. So I don't know what's going on here. But at any rate, without the zinc and without controlling for timing, I got to say I'm given a C- to a D on the study design for this one. Unless there's something that didn't show up anywhere in the clinical design protocol, which I read, unless there's some other stuff, some supplementary materials I don't know about or couldn't get access to, I'm going to give this one low marks for the study design. I think it looks designed. I will not be surprised to find out that this one fails. But one of the things I really hate or despise is politicized medicine. This is in CNN. This just came out yesterday on the 14th of May. Look at this. This is all in the context of a big, heavily political article about Rick Bright. I'm not going to wade into the politics. I don't do politics. Politics isn't my thing. As a quick reminder, I don't do left-right. I do up-down. My up-down is integrity. I'm seeking to operate in and with as much integrity as possible. The ideological rigidity thing that's on the bottom of that whole thing, I don't do that. But I do believe some of these studies, I gotta confess, my best explanation for them is that to harken back to the opening email of the day, it's not really bad science. I think it has some other explanation, and I think politics is cutting into some of this stuff. Sad to say, but at any rate, that's speculating. Here's what we do know. CNN writes it thusly. On Monday, a study of more than 1,400 COVID-19 patients in New York was published in the Journal of the American Medical Association, the largest such examination to date, which found that hydroxychloroquine gave no benefit to COVID-19 patients and instead significantly increased their risk of cardiac arrest. Oh, that sounds awful. We'll call that study 1. We're going to look into that one in just a second. Monday's JAMA study followed a New England Journal of Medicine study that was published last week that concluded hydroxychloroquine neither helped nor harmed 1,376 patients who were admitted to New York Presbyterian Columbia University Medical Center between March 7th to April 8th. We'll call that study number 2. As a result of these studies, Dr. William Schaffner, an infectious disease expert, said the nail has virtually been put in the coffin of hydroxychloroquine, which will make this man, Dr. Fauci, very happy because, of course, then HCQ will not compete with his favorite star, remdesivir, which, by the way, doesn't really seem to do all that much. I looked at all the clinical data, and I got to confess, at best, that's sort of a squint at it, kind of maybe sort of thing. And they gave that one every possible benefit of the doubt, controlling for timing, controlling all the dosing, all of that stuff. And it still came up kind of questionable. So let's look at study number 1. Here's study number 1. This came out on May 11th. All but guaranteed to fail. This one was. All but guaranteed to fail. So this is pulling from the study. Let's look into it. This one's called Association of Treatment with Hydroxychloroquine or Azithromycin with in-hospital mortality. So they're looking at death in patients with COVID-19 in New York State. All right, let's dive in here. Hospital outcomes by treatment are presented in Table 2, noting 45 or 3.1% of patients were still hospitalized at the time of final analysis, so I guess they're excluded. Patients receiving hydroxychloroquine plus azithromycin, that's 30.7%, and HCQ alone, which was 19.2%, had higher levels of ICU admission than those receiving azithromycin alone, which is only 10%, and neither drug. So, gosh, if you were given hydroxychloroquine or azithromycin or HCQ alone, you had higher levels of ICU admission. Gosh. Well, first question, were these drugs administered in a randomized, blinded method? Nope. These patients came in and somebody made a decision. We're going to give you something. Okay, now let's check this out. Although, they do mention here, 56.1% of patients in all groups entered intensive care within 1 day of admission. We can't look at any of this stuff. More than half, nearly 60% of patients in all groups entered intensive care within 1 day of admission. I'm sorry. Somebody was just, Hail Marying a little, some drug treatments to people who were right at death's door, so to speak, or right into the ICU's door. Similarly, does it get worse? More patients receiving hydroxychloroquine plus azithromycin and hydroxychloroquine alone than those taking azithromycin alone and neither drug received mechanical ventilation. What? Hold on. How do you control for something like that? You can't. Come on. Stop. Right there. So more patients receiving HCQ and HCQ plus than those taking azithro alone and neither drug received mechanical ventilation. So look at this. The people who were on, and this supports my Hail Mary hypothesis, people receiving hydroxychloroquine and plus azith, 27% of them received mechanical ventilation. And hydroxychloroquine alone, 18.8% got mechanical ventilation. Only 6.2% and 8.1% received mechanical ventilation. So my guess here is that the people who were, as they say, people who are more seriously ill tended to be put on these drugs. So that's a super confounding factor. I don't know how statistically you'd tease that apart. I'd love to talk to somebody who could really tear that apart. And look, here, let's go to the last sentence. Among patients undergoing mechanical ventilation and receiving HCQ plus Z, or HCQ alone, or Z alone, 49.6% were ventilated before or concurrent with starting these treatments. We're out. Right there. No good. That's bogus right there. Okay. You got to start the treatment early. By the time, if you're saying half of the people who went on either azithromycin, HCQ, or both of them together, that half of them were ventilated before or concurrent with starting these treatments, no, you can't possibly tear through the data and correct for that and then come up with a thing that says, there's no way to interpret these results. I'm so sorry, but you can't take an somebody on Twitter the other day said, hey, airbags were administered in the hospital to car crash victims after they were brought into the hospital, and it's been determined that airbags don't work. Did you follow that? Right? That's really what they're saying here. They're saying an antiviral that really only works before people get super seriously sick doesn't work when we give it to them after they're already ventilated. And I'm here to say, yeah, that's not too terribly surprising, really, honestly. It just isn't. So that doesn't surprise me. All right. But at least study one was honest about the limitations. So I love this part. This is where honest researchers, I think, really show themselves and reveal themselves. So down at the bottom of this study, they did have limitations and says, this study has several limitations. First, in sampling first hospitalizations, possible readmissions to other facilities may not be captured. Okay, that's fair. Second, mortality was limited to in-hospital death, and patients discharged were assumed to still be alive during the study period. Okay, that could confound things if everybody went home and died. That would obviously change the conclusions here. No data that happened, of course. Third, some potential confounders, such as inflammatory markers associated with severity of COVID-19 in prior studies, were not frequently measured and not available for modeling. So they didn't know how far along some of these people were based on inflammatory markers. But here's where number 4 is the one that I want to lean on a little bit here. Fourth, the rapidity with which patients entered the ICU and underwent mechanical ventilation, often concurrently with initiating HCQ and Z, rendered these outcomes unsuitable for efficacy analyses. There it is. It did indeed render these unsuitable for efficacy analyses, particularly if your endpoints were mechanical ventilation and death, right? And finally, fifth, adverse events were collected as having occurred at any point during hospitalization, potentially before drug initiation, although both medications were started on average within 1 day of admission. Future studies should examine the onset of these events relative to drug timing. Yes, timing. Timing is really important. But let's go back here for a second. Rendered these outcomes unsuitable for efficacy analyses. You got to be able to see that and read that and know what you're reading when you see that, but I expect that from our doctors. And I would especially expect that from a doctor who's billed as an infectious disease expert. Hey, Dr. William Schaffner, I don't know how you can say the nail has virtually been put in the coffin of hydroxychloroquine based on study 1, which has the limitation of not being suitable for an efficacy analysis. Okay? Bad. That's a fail right there. Okay. There are 2 key variables for HCQ. Zinc is one, time is the other. Let's go into study number 2 and see where that brings us. Okay. This is actually another poorly designed study. I'll show you why. This came out May 7th. So this was study number 2, where they were saying here, neither helped nor harmed all these patients. And so this is the prime conclusion here at least in CNN. I have a different conclusion. Once again, we'll lead off by noting that when we do a search for zinc, no zinc anywhere in this entire document. So it's not discussed either to say why they're not discussing it or why they didn't study it. But check this out. So 1,446 consecutive patients, 70 intubated, died, or discharged within 24 hours after presentation, therefore excluded from the analysis. All right. They had a remaining 1,376 patients. During a median follow-up of 22.5 days, they found 811, so that was 59%, I'll round up there, received HCQ, which was 600 milligrams twice a day, BID on day 1, and then 400 milligrams daily for median of 5 days, so 6 total days of treatment there. 45%, I'll round up, 46% of the patients were treated within 24 hours after presentation to the emergency department. So, okay. And 86% within 48 hours, which means 14% weren't given anything within 48 hours. So I would consider excluding those as well. But here we go again. Ready? Hydroxychloroquine treated patients were more severely ill at baseline than those who did not receive hydroxychloroquine. So again, Hail Mary pass. The more seriously ill patient gets the drug, also at a too late moment, and at that point it didn't work, and then they write a big paper that says, hey, it didn't work, and we're all supposed to shoot our eyebrows up in complete surprise and say, wow, that's insane. How did that happen? Median ratio of partial pressure of arterial oxygen to the fraction of inspired oxygen was 223 versus 360. Oh my God, that's just a giant gap. 223 versus 360. So the HCQ treated patients were really, really seriously ill compared to the other people in this story. All right. Overall, 346 patients had a primary endpoint event. So in this case, it was either intubation or death or both. And 166 died without intubation. So 180 died, were intubated, 66 died, 166 died without intubation. In the main analysis, there was no significant association between HCQ use and intubation or death. So they said, yeah, it didn't really work. All right. Obviously, it didn't really work, but I'm really surprised that you said there was no difference because I'd have to see how they actually ran their statistics because that's insane. But study 2, where was it really falling short? I went looking for their discussion of limitations. This is the only thing I found. There was just one word of limitation here. This is it. This is the whole thing. They didn't have an entire limitations section. But let's sort of dig through this real quick. In the main analysis, a multivariable regression model with inverse probability weighting according to blah, 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 blah. I don't know. I'm just bored. I can't be bothered with that. So despite this extensive adjustment, yeah, I'll bet it was extensive, it is still possible that some amount of unmeasured confounding remains. Let's talk. Here's where they get down to it. Additional limitations of our study include missing data for some variables and potential for inaccuracies in the electronic health record, such as lack of documentation of smoking and coexisting illness. What? Okay, so never mind. Listen, you want to know what the main limitation of your study was? It was that it wasn't randomized because the more severely ill patients got the drug. So pretty much impossible we're going to be able to get anything out of that. It failed because your limitation of your study was they didn't give the HCQ in a timely fashion. And a big limitation of your study was you didn't understand that zinc was an important part of this overall story. And you didn't even talk about the fact that you didn't know about that. So I put all that together and I say a couple of things. First, the nail has virtually been put in the coffin of hydroxychloroquine, which is going to lead me to say that Dr. William Schaffner may be an awesome infectious disease expert, but he's a clinical numbskull. He doesn't understand how to read clinical stuff, so I will put that right out there. And two, CNN is very, very, very heavily slanting all of this, and I think they're doing it for politicized reasons because here they are discussing these things in the context of a very, very political moment with this person who is being put forward as a whistleblower against Trump and Trump's administration. And all that may be true and yada, yada. I don't do left, right. Doesn't bother me in the slightest. But the science behind this, this bothers me a lot because this is bad science and bad conclusions. All right, very quickly then, and moving on, the New Zealand piece yesterday caused a little bit of a stir where I showed that there was a big difference in response in the data between New Zealand and Britain. Britain coming out looking pretty bad. A lot of people push back. This is just a representative sample. Dude, New Zealand has a whopping 5 million people. You can't really compare that to the UK. Yeah, that's all well and good, Chris, but now look at what the government of New Zealand has done. Passed a law this week to allow people to enter your house without a warrant. Tyranny. Okay, I don't confuse the political aspects because listen, you won't get any argument from me that the political overreach, the loss of civil liberties, the absolute grotesque displays of petty tyrant power, all of that's on display right now is a whole separate conversation. I was just saying the numbers, by the numbers, who's doing well, who's doing bad from a country standpoint, all right? This person writes, there's a difference between gold standard pandemic response and turning your island nation into a prison. Again, that wasn't the point I was making. New Zealand prioritized healthcare workers. With all due respect, you have no clue what you're talking about. My wife works in a large, busy, open plan office in the hospital and was prohibited from wearing a mask for fear of raising anxiety in other staff. And this is a government hospital. So that's a great point. Listen, I don't live in New Zealand, so it's entirely possible I don't know what I'm talking about. So if New Zealand is not prioritizing healthcare workers, then that's not a good thing. Because I kind of hope that was true. And from stuff I read, it was true, but Porcinophile says, nope, not true. Jillian writes, I think he's comparing the proactivity of the response and the clear strategy of fighting the outbreak, which is totally fair, and which many countries did far better than the US, UK, or US. That's exactly right, Jillian. That's what I was talking about. There was a really nice piece put up by Shan here, and let me just make this a little bit bigger. Don't worry about reading the table. I'm going to make this table super big in the next slide. And what I like what he did here is Shan writes, you see many headlines and things have been heavily politicized with COVID-19, country experiences being used as weapons for party or personal narratives. I think some of them are on display here. That's absolutely true. Here's the actual data offered with little commentary. See the second part of this tweet for what the colors mean and country choice. So let me blow up this table right now and let's compare. So here are countries with relatively equivalent populations. And you can see that the color coding says I think it's green. This is sort of an orange color, red and black. So Ireland has 4,833 cases per 1 million, 305 deaths per million. But Slovakia, which went in Chechnya, both of which are doing a really good job with masks for all and all that. In New Zealand, let's compare them now. And we see 5 deaths per million and 4 deaths per million for Slovakia and New Zealand, respectively. Total deaths, 1,500 versus 27 and 21. So you can see clear differences here. What about Panama and Costa Rica? Roughly equivalent populations. But here you've got 830 cases compared to 8,944. 256 deaths compared to 8. 59 per million versus 2 per million. By the way, Costa Rica has been running hydroxychloroquine as early in the treatment cycle, and they're not quite as concerned about making sure everybody's got a positive test and practically on death's door before they administer it. Getting great results from that, by the way. The Belgium and Netherlands compared to Czechia. So roughly equivalent populations, very different outcomes in terms of total cases, very different outcomes in terms of deaths per million. And then Sweden and Denmark. Sweden's in orange, and I'm going to let Shan explain why he put that in orange in the next slide. Sweden has twice the population, but Denmark's more densely settled, so maybe we can compare them. But here we have 350 deaths per million compared to 93. So I think this is a really useful way to sort of compare countries, and thank you, Shan, for putting that together. So here are Shan's interpretations. These countries are peers from a geo perspective and or population, picked for stories being told, not really cherry-picked. Green are those with strong and best practices around pandemic response. Red are examples of controversial or egregious attitudes right from the beginning. Sweden was colored orange, because although they have been in the headlines quite a bit, I don't consider their response egregious. They weren't as lax as the headlines might have suggested. They did have a plan and were more lax, a bet that hasn't paid off, clearly. All right, so I do want to get back to, and thanks for that, Shan, I think that's good interpretation. I want to get back to this, though, this whole idea, which is important. It's a subject I've been sort of steering away from for a while, but I think it's time, which is, well, what is about this tyranny? What about turning your nation to a prison? What about all that stuff? All right. Now, I said a long time ago it's time to have our hard conversations around all this, so let's have that hard conversation. First, your choices when faced with a pandemic is you could do nothing, right? Or maybe we could go back to medieval times and we'll pray to have the vapors taken away or whatever, right? We'll just be anti-scientific and we'll just hope for the best, or we'll just let it burn through like Boris Johnson was saying yesterday in that video. All right, on the other end is from doing nothing is you get all the way over to welding people into their homes until they starve to death or something, right? So let's imagine there's a whole spectrum in here, and every one of us is going to fall somewhere on this spectrum. And I believe that reasonable, clear-eyed, intelligent people can have completely different opinions about what we should be doing here in terms of our response, in terms of where that public versus private, the freedom versus, well, let's put it a different way. The spectrum might be from complete freedom. You can do whatever you want at any point in time to living in some authoritarian nightmare, all right? Again, people can have very reasonable and very different outcomes in terms of where they fall on this particular line. So as we want to start thinking about where are we going to start drawing this line, right? There's some point we've got to draw this line somewhere in here, and there's going to be a whole set of responses that fall out around that. And hopefully we have really good, clear, crisp, very transparent debates about all of this. By the way, just so you know, my bias is that I think that a lot of what we've seen in the countries that have managed this poorly have been confounded by people who are working against the best interests of their own country because they're conflicted, because their jobs, because of money, because of ideological bias, because fundamentally they're just confused individuals that are either somewhere really partisanly on the left-right divide, or they've got some strong, overbearing ideological rigidity that prevents them from thinking clearly, or it's just money, right? Something like that. All right. So here's the reality, though. First, honey badger virus. Some people call it COVID-19. It isn't going away. It's this generation's portfolio. It's here, right? I don't even think it's going away for the summer or even lulling, right? It's here, and we're going to have to deal with it, right? That's part one. Part two is more people are going to die from COVID-19, and that's just the reality of this particular virus, and that's going to be true. As well, it's also true that people are going to die and suffer from economic issues. I don't know if you remember, but there was a piece in a movie with who was that was doing, I forget. Anyway, I'm going to blow it. But the quote out of the movie is that for every 1% uptick in unemployment, 40,000 people die. A lot of them from suicides and things like that because they lose their jobs and they lose their will to live and all of that. So we have to balance these things. I've been talking about that for a long time. But I think the sooner we can get to another recognition, another point of acceptance is that old economy is not coming back. Ever. It's just not coming back. The old economy was based on 50 years of steadily increasing debt levels, and it was predicated on this ridiculous notion that we could always borrow from the future, and by the time we got to the future would be big enough to pay back whatever we borrowed, right? We're going to have to live within our means, and we're going to have to live within our means economically, we're going to have to live within our means ecologically, and we're going to have to live within our means in terms of energy and energy outputs and things like that. So all those things are true, and the old economy is not going to come back. For parts of it, I'm going to say good riddance. There are parts of it that didn't serve people, that were frankly soul-destroying, that were not any good for us anyway. So all of that is fine. So as we think through this reality, these realities, right, these are the realities. The virus isn't going away. People are going to die from COVID-19. People are also going to die from the economic issues that result from this. We have to balance those out. But we also have to release this idea that if we just did a couple things right, chanted a couple incantations, we would get our old economy back, because it's not coming back. It means more living within our means. It might mean that you as a journey tradesman carpenter don't buy a $62,000 F-150 to get you to work. It might be that you don't need that brand new truck going forward and the 8 years of payments that go with it. It might be that you need to save and then buy the truck that you can afford. And that will be the economy going forward. More of that. All right. These second waves, they're going to happen. And we know this because they're already happening. And the second waves, they're plaguing Asia's virus recovery here. This is in Bloomberg from yesterday. They talk about an elderly woman with no travel history. So it sounds like community-acquired disease. An unexpected flare-up in a nightclub, a swelling cluster in towns near international borders with no discernible source. This is the honey badger virus. Give it a slight opening and it comes roaring out again. After containing their outbreaks through measures from strict lockdowns to rapid testing regimes, the Asian economies that have seen some of the most success quelling the coronavirus, Hong Kong, South Korea, and China, are now facing resurgences that underscore how it may be nearly impossible to eradicate it. That gets us back to number one here. It's just not going away, right? It's a painful reminder that as countries open up again and people resume normal life, untraceable flare-ups are likely, and they should be expected, even after an extended lull in cases. Scientists have warned that the disease may never go away because it lurks in some people without causing any outward signs of sickness. And again, I'm glad that we're finally there talking about that, because this whole idea of asymptomatic transmission had that on February 2nd. So glad to see we're finally getting there. As well, this article continues, there's a growing consensus the virus won't just go away, unlike its close cousin that caused SARS back in 2003. People who contracted SARS were immediately invisibly ill, so they were symptomatic. And once they were quarantined for treatment, transmission was halted. So that symptomatic transmission, boy, that made it easy to stop. Relatively easy. This one's super hard. But the new coronavirus manifests in many people with few, no, or uncommon symptoms, thus ensuring that hidden chains of transmission endure, and cases will likely spike seasonally, like with the flu. I'm not sure about this. Why? Because we see countries with summer-like temperatures having really bad runs of this. That includes Ecuador, Brazil, places like that. Moreover, people infected with SARS were not contagious during the virus's incubation period or even in their early days of being sick. In contrast, the new virus doesn't necessarily make people sick, but can easily transmit while it's still incubating, making early detection and containment impossible. I'm going to strengthen up that word difficult for them there. So we have to find ways to live with the virus for now, and this is the new normal, says Takeshi Kasai, WHO's regional director. As long as the virus is circulating in this interconnected world and until we have a safe and effective vaccine, everybody remains at risk. So once again, to live with a honey badger virus like this is a very, very severe foe. You got to treat it very carefully. I think our plans have been entirely too unsophisticated in the U.S. Plan A, keep everybody locked home until a vaccine arrives. Bad plan. Plan B, reopen everything. Bad plan. You need to really understand how you're going to go about modifying the culture so that people automatically on their own, where everybody's wearing a face mask, we're good hygiene practices, washing public surfaces, our hands, things like that, practicing social distancing, things like that, all very important parts of this. We're all in this together. So I really wish it wasn't, what's the government doing? What's it not doing? What are people doing? We're all in this together. It's not the government and the people. It should be all of us taking responsibility individually, collectively, for what we need to do to live with this virus because it's part of us now. So I think we've gotten there. I think we've stopped the pandemic. The data all says that. The R0 has gotten below 1 in a lot of cases or close to 1. That's because of these non-pharmaceutical interventions and all these other containment and isolation actions. This part's starting to really bite, of course, and this is I don't think we can go another month or two without opening things back up, but I don't know how we do that, given the fact that a lot of what we used to do, I don't think makes sense anymore. So even if you open the economy up, are we going to have concerts again where there's tens of thousands of people in a stadium? Are we going to open up a thing like Disney World where, people are all crammed together and riding on rides where we all grab the same handrails and things like that? I don't think so. Cruises, all of that, dead. I don't even know that it's possible to resurrect the economy and get it back to its old self. We're going to have to do something new. What are we going to do with all those people who used to work at Disney and on cruise lines, right? And they need different and new jobs. And by the way, there's a ton of things that need doing. And if we had proper leadership, not crappy managers, we'd have all those awesome things happening, right? So we're going to need, gardens installed in every plot, and behind old people will need help putting gardens. And we're going to need new permaculture methods all over the place. We're going to need brand new ways of telecommuting and finding ways for people to work from home. There's just a billion new things we need to do. So we need to get there as quick as possible. And I'm not as worried about keeping the hospitals working anymore. I think we've shown that we know how to balance this 1 and 3. I'm a little worried how we get number 2 back on track here now. And the only way we're going to get there, of course, is if we operate with really high integrity. We don't allow partisan politics or ideological rigidity to begin coloring our clinical trials, our policies, what kind of, draconian tyrannical laws get passed, all that stuff. By the way, no, I don't happen to think that violating all our civil liberties is the right way to go with all of this, because that creates an us versus them. And the next thing you know, people react badly to that. So instead, it needs to be inclusive, not exclusive and divisive. All right. So with all of that, here we are at the end. Conclusions. Studies on hydroxychloroquine. They're pretty much designed to fail. That bothers me. Not controlling for the time of administration, not administering zinc. It's kind of inexcusable and it's very bad. And it's not even science. I got to take that word out. It's something else. It's not science. And that's what I learned from our opening email. It's something else. I don't know what it is. Hydroxychloroquine has become politicized. That's unfortunate. It's really beyond tragic if it turns out that it actually works. If and when a proper study shows efficacy, though, I'm wondering what sort of penalties really need to apply to the people who are purposely designing studies that are meant to fail. I just, and again, it might not work. What do we need? We need a double-blind, placebo-controlled trial where zinc and the time of administration are controlled for. Of course, that's the same thing we've been saying for months. But at any rate, wouldn't that be great if we had that data? It would. That would be awesome. It's clear we have to strike a new balance with HB19. Look, if we were smart and we had cultural integrity, I think we could do it actually pretty easily. We would have masks, we'd have distancing, individual responsibility, people would be taking it seriously, all of that. But my prediction is at least another year of flailing about. And some communities are going to do better than others. There's a reason I moved to the community I did here in Western Mass. There's a reason I live where I do. I truly would not want to live around people who are unable intellectually or ideologically to grasp what's required to get on with life. I'd rather live around thoughtful people who can manage all of this. And so I think local mileage is going to vary tremendously. Second wave is assured, but I'm not really sure you could call it a second wave because it's really just a continuation of the first wave, as are third, fourth, fifth waves, all of this, right? That means it's time for you to adjust accordingly and really think through, it's not just the quarantine, but what does the next year look like for you? And what is the next 2 or 3 years? What if this continues, right? These are all really important questions because, listen, we can all be hopeful that we're going to get a vaccine out of this that actually works and goes through proper safety and efficacy studies. I'm not as hopeful I can't rest on that alone. I'll hope for that, but I have to have a different strategy. And so that's when I say time to adjust accordingly. You need a strategy that will help you adjust to this new period. By the way, I'll bet you anything, because I said this, I'm going to get some more nasty Twitter feeds and some very upset doctors are going to say things about me and all of that. And I'm probably going to be called, bad names and all of that, which brings me back to my rule of life that when I'm faced with emotional outbursts, I know I'm dealing with belief systems, not opinions, not science, not logic, not all of that. All right, remember to resubscribe if you need to, and remember to plant a garden. If you've been to the store lately, you've already seen that fresh veggies are starting to get a little tight in supply. I think that's going to continue. A lot of reasons for that. So as well, you can get free vitamin D with every garden. Now, with every garden. Take your shirt off and have some skin exposed and when the sun's out, and you will get free vitamin D and better food. So with that, hey, have a great weekend. Of course, I'm taking the weekend off. Got a lot of gardening to do. Have a great weekend. We'll talk to you back. We'll be back with you on Monday. All right. Bye, everyone.
Hi, folks. Adam Taggart, co-founder of Peak Prosperity, here with good news. In his daily videos, Chris often refers to the book that he and I wrote, Prosper: How to Prepare for the Future and Create a World Worth Inheriting. It presents a practical model for living with greater resilience, and those who read it and followed its advice were much better prepared for the coronavirus outbreak than the average household. Given its heightened relevance to the turbulent times we now find ourselves in, Chris and I want everyone to benefit from this book's formula for better, more secure living. So we're giving the book to you for free. To get your copy, simply visit peakprosperity.com/freebook. We think you'll find this an extremely valuable and inspiring resource for the current COVID-19 outbreak and for being well positioned for any kind of crisis that comes our way in the future. Thanks for listening, and happy reading.